here. Thank you, WeSpark, for having us. This is really exciting, and hopefully we have a lot of good information for you today. So I do want to share a little bit about Sharsheret with you. So Sharsheret means chain in Hebrew. We're a Jewish not-for-profit organization that provides free and virtual personalized support, life-saving education, financial assistance for non-medical needs, and genetic counseling to empower those of all backgrounds faced with or at increased genetic risk of breast cancer and ovarian cancer. Our social workers and genetic counselors are here to help you navigate the cancer journey before, during, and after diagnosis with free support and resources, including caregiver support and kits that we send in the mail, like our Busy Box for families with young children that comes with on talking to your kids about your diagnosis. And we have our Thriving Again kit, exercise bands, and more. We also do a tremendous amount of webinars that can be found on our website at sharsheret.org. And I know that Michelle will be sending our contact information and a link to an informational brochure at the conclusion of the program. So look for that. It's got a lot more information on there. And so as we move into the program itself, I want to remind you that the information provided by Sharsheret is not a substitute for medical advice or treatment for specific medical conditions. You should not use this information to diagnose or treat a health problem. If you have any questions that are specific to your medical care, we recommend that you speak directly to your medical provider. And so before we begin the official panel, I'd like to introduce you to one of our incredible Community Advisory Committee members, Elisa, who's going to share her personal story with you.
Thank you. Thank you so much. Okay. Well, they say knowledge is power, but I've learned that support is everything. I'm so grateful to be here this afternoon to share something deeply personal, something I didn't always feel ready to talk about. When Melanie called and asked if I'd speak, I said yes without hesitation. But as soon as I hung up the phone, I thought, wait, did I really just agree to this? But I realized I wanted to, because if sharing my BRCA journey helps even one person feel less alone, it's worth every moment. My mother passed away almost 35 years ago from breast cancer. That loss has never left me. Back then, the BRCA gene was only starting to be understood, but I knew I needed answers. So I took the genetic test. Out of pocket, no insurance, because if you were BRCA positive, you risk being uninsurable. Years later, I connected with Sharsheret, an organization that became a lifeline. In 2018, I had updated testing at Cedars. The results, a variant of unknown significance on BRCA2. Basically, we're not sure, but we'll keep an eye on it. I connected with Peggy, a genetic counselor at Sharsheret, who guided me through unfamiliar territory. She offered clarity and reassured me that I wasn't alone. From time to time, I check in with her, always seeking that sense of direction. And then 5 years later, I got that call. My variant had been reclassified. I was now officially BRCA2 positive. I was stunned. The first person I called, Jenna at Sharsheret. She knew exactly what I was feeling. She showed up the next day just to give me a hug and a beautiful Sharsheret robe. That small gesture meant everything. In November 2023, I made the decision to move forward with prophylactic surgery. It wasn't an easy choice, and the road to recovery was long and challenging. But it was a decision I made thoughtfully and on my own terms. Throughout the journey, I was surrounded by unwavering support from my husband, children, family, and close friends. Their care, along with heartfelt messages, thoughtful care packages, and meaningful connections through Sharsheret, made all the difference. I never walked this path alone. At first, I was private about my journey, but during a Sharsheret advisory board meeting at my home, something shifted. I spoke my truth out loud. It felt right and it felt necessary. Now I'm proud to be a Sharsheret peer supporter, walking alongside others as they navigate similar paths, because I know firsthand just how powerful connection can be. We've come so far in understanding genetics, but no one should have to face this alone. That's why Sharsheret is so vital. It's not just about medical answers, it's about emotional support, empowerment, and community. If there is one key message I would love to convey this afternoon, is that support holds greater significance than fearlessness. I am sincerely grateful to Sharsheret for providing me with that crucial support. Thank you all so much.
Thank you, Elisa, for sharing. It's really important, I feel, as I as well am BRCA1 positive, and I also had my prophylactic surgeries after seeing my aunt go through ovarian and breast cancer 3 times. And my grandmother had breast cancer in her 30s, and her mother passed away in her 30s of breast cancer. So it was something that I agree it's important to get on top of it and to understand how it works and what your options are. And yes, Sharsheret is here to support through every step of the way. And we are here for everybody. So I want to go ahead now and introduce our panelists. So we have joining us Bita Neharai. Bita is a licensed board certified genetic counselor specializing in cancer genetics. She received her master's degree in human genetics and genetic counseling from Stanford University. Ms. Neharai joined the City of Hope Division of Clinical Cancer Genomics in 2012, where she provides cancer genetic services for patients and families suspected to have a hereditary predisposition to cancer. And we also have here Dr. Adam Braun. Dr. Braun practices hematology and oncology at UCLA Health Clinics in Westwood, Santa Monica, and Porter Ranch. He has volunteered with Sharsheret for several years to spread awareness of current cancer screening guidelines and how to navigate the medical system to get what is best for each patient. So thank you both for joining us today. I'm going to just pin us so that everyone can see who's talking. Okay. So I'm going to start by asking some questions. We do have a few ahead of time that we got from some of our attendees today. And then we will leave time at the end for additional Q&A that come up during the talk, if anybody has. So I invite you guys to unmute. And I'm going to start with a general question for both of you. So when you are talking to a new patient and asking about their family health history, what are you looking for?
Yeah,
Wants to start.
I can get started, and then I'll popcorn to Dr. Braun. So as a genetic counselor, my role is routinely to meet with individuals and families who are suspected to be at risk for hereditary cancer, and that might be because they either have a personal history and or a family history of cancer. And so as part of that visit, we take a pretty in-depth family history. And what we're looking for overall are patterns that would make us more or less suspicious or help us understand what might be explaining the cancers in the family. So it's helpful to know who in the family has had cancer, what types of cancers they had, at what ages they were diagnosed with cancer. Any additional information just related to their treatment can sometimes be helpful as well. For instance, was it breast cancer in both breasts or just one breast, or other features specific to their cancer? It's also helpful actually to know about who in the family who hasn't had cancer as well. So we take a extensive pedigree of family tree, and it's really important to, we keep in mind both sides of the family. So your mother's side as well as your father's side of the family is equally as important, as well as multiple generations. So when we take a family history in genetics, we'll be asking about you, but also children, brothers and sisters, parents, aunts, uncles, cousins, grandparents, and looking pretty extensively at some of those features. Understanding that not everyone has that information, but we gather whatever information you have available to help build out, the information to try to better understand your overall risk.
I think as Pita said, this is the most important part is really getting that whole family history, because otherwise you can be missing, important key features to be looking for. Or, on the flip side, you might be overcalling and over worrying people too if someone, doesn't have a particularly high risk and you don't want to necessarily send them onto, uh, more higher intensity types of preventative management. So I think so it's always good to be from the clinical side, in the doctor's office, but usually before the reference to the genetic counselors, although not always, it's helpful to get a sense of all of that, and then also to get a sense just of, especially for breast cancer history, just a sense of kind of puberty, what happened, kind of the anything that's come up before with lumps or bumps kind of throughout life can be pretty telling as well.
All right, thank you. So for beta, what is the risk for being a carrier of the BRCA mutations and other breast cancer related mutations? How does the risk for being a carrier change when you're talking about the Ashkenazi Jewish population specifically?
Yeah, those are great questions. So, in general, when we think about the BRCA1 and 2 or BRCA genes as an example, those two genes, just to provide some more information for those who may not be familiar, are the two of the genes that are the more common causes of hereditary breast and ovarian cancer, but they are not the only genes, which is why, and Elisa, thanks for sharing your story, right? Updated genetic testing, and we can talk more about that later as well, can always be helpful to make sure that you've had a comprehensive look. In general, we estimate that about 1 in 450 people will have a BRCA1 or BRCA2 mutation. So, less than 1%, but still more common compared to when we think about, rare disease and things of that nature in general. Where ancestry comes into play, and that's another thing that I forgot to mention that we also capture when we're taking family history, is we know that there are certain ancestral or ethnic groups that have a higher prevalence of certain types of genetic conditions. And so for the BRCA1 and 2 genes specifically, there are more common mutations, which are basically harmful genetic changes that increase your cancer risk. And so about 1 in 45 to 1 in 50 people who are Ashkenazi Jewish or Eastern European Jewish will carry one of those BRCA1 and 1 or 2 mutations. So the sort of chances jump about tenfold, which is why when we think about, who would benefit most from genetic testing, sometimes it doesn't take a lot of personal or family history factors to qualify for genetic testing. So it's important to make sure that you're, advocating for yourself, talking to your healthcare providers if you have questions about the sort of pros, cons, and of testing itself, and if that's something that may be helpful for you. In general, like thinking about other gene mutations, so there are a number of hereditary cancer syndromes. Some of them are more common than others. Some of them have high risk, others have moderate risk. So there's another condition called Lynch syndrome, and about 1 in 200 to 300 people have Lynch syndrome. So that's actually even more common, and that's something that could be linked to things like colon and uterine cancer. So each syndrome varies, and that's where, again, the collection of your medical and family history information can help give us a sense of what is the likelihood that you might carry one of these conditions, so that we can offer and facilitate the genetic testing that may be right for you.
All right, and can you explain a little bit about why the Ashkenazi Jewish population is more at risk?
Yeah, that's a great question. So part of it is just that, genetics and history are very much intertwined. And so, it's what we call a founder effect. And this can be seen also in other populations, but has just been very well described and studied for people who are Ashkenazi Jewish. So when you think about that particular ancestral group, over time, you might have seen that mutation, a BRCA mutation, occur in 1 in 500 people. But then because of historical events, like pogroms, other things where the population then shrunk significantly, you now are maybe seeing that mutation present in 1 in 50 people, right? And then as that population regrows, and there are other cultural factors like, intermarrying because of faith or other factors, we then end up seeing a higher carrier frequency in that particular group for BRCA1 and 2. And it's also observed for other types of genetic conditions as well, for other groups. And so really, it's important to, if you know about your ancestry and what country or countries your family comes from, that can be really helpful as part of your assessment.
Thank you. And then how do BRCA or other mutations run in families?
Yeah.
And a side question, how often do they come through the male side of the family? So let's talk also a little bit about the risk men have for cancer if they carry these mutations.
Yeah, really great question. And then I also want to say we're seeing great questions come in through the chat, and we'll make sure to get to those as well. So we're not ignoring them, but we'll make sure to touch on them. So most of these hereditary cancer syndromes like BRCA and others are inherited in what we call an autosomal dominant or dominant manner. And so one way of thinking about that, I often use my fingers. We all typically will have 2 copies of each of these genes because we get 1 copy from each of our parents. So 2 of BRCA1, BRCA2, and MSH6, like put in the chat and so forth. And in these cases, for most of these conditions that are dominant, it only takes 1 of your 2 copies to have that mutation, that gene change, to cause the increased risk for cancer. Now, genetics is not destiny, so some people carry mutations and never develop cancer in their lifetimes, but you are at a higher risk as compared to someone who doesn't have that mutation. So 1 copy has a mutation, the other one does not. And so when we think about that, we also know that these genes are typically on chromosomes or genetic material that's shared by men and women. So men and women are equally likely to carry these particular or inherit these particular gene mutations, which is why I mentioned earlier, dad's side of the family is equally as important. Half of hereditary breast and ovarian cancer comes from dad's side of the family. Things like prostate cancer and others that, cancers that affect men can also be passed down through mom's side of the family. So it's a 50-50 chance. And then it's also then a 50-50 chance for you to pass on a mutation to a child because you share half of your genes with each child in each pregnancy. So men are equally likely to be carriers of BRCA1 and 2. The difference is then just thinking about the types of cancers that they are predisposed to and the level of risk. So BRCA1 and 2 primarily increases risk for things like breast and ovarian cancer. And the breast cancer we can also see in men. So we think about screening related to that as well, though the risk is thankfully lower than it is in women who are BRCA carriers. But then there are other cancers that come into play that are relevant for men, like prostate cancer, pancreatic cancer can also be seen, or melanoma in some of our BRCA families as well. So it's, a lot of times it's a misnomer that, dad's side of the family doesn't matter. But really both sides of the family are equally important. And there's relevance for either cancer risk or family planning purposes or other factors for men and women to consider genetic testing.
Thank you. Yes, my BRCA1 mutation came from my dad's side. So yes, that is
thanks for sharing
firsthand.
that, Melanie. Yes.
So tell us a little bit about how genetic testing is performed. Does everyone need to be tested? When can we start testing, etc.?
Yeah, so I would say in general, we think about genetic testing for cancer predisposition most often in adulthood, though there are exceptions. And I know that was a question in the chat. So a lot of when we consider genetic testing, and then I'll talk about how we facilitate it, but when we consider genetic testing is dependent on that condition and when we typically see cancers or the other, consequences of that condition arise in an individual. So for BRCA1 and 2, Lynch syndrome, other hereditary cancer syndromes, it's typically seen adult onset, meaning after the age of 18, and actually typically well beyond after the age of 18. So we don't typically do testing in folks under the age of 18 for those types of conditions for a number of reasons. One being that the recommendations for care, whether it's increased screening or risk reducing prophylactic surgeries or medications that can be offered to reduce risk, those don't start until someone is typically at least in their 20s for most of these conditions, sometimes even later in their 30s and 40s, depending on the gene. So that's one reason is we wouldn't change their care. The other piece is also wanting to be mindful of that person's autonomy. Genetic testing is a very personal choice. And so while I think we'll talk a lot about the benefits, there are definitely some people where maybe genetic testing just isn't right for them. And so that's like a conversation to think about, is it the right thing for you? How is this information going to be used for you and your family so that you can make that decision for yourselves? And so we want to make sure that that individual then has that opportunity to be involved in that decision making. So those are some of the reasons why we hold off on testing minors for some of these, though there are other hereditary cancer syndromes where we can see cancers occur at younger ages, like in infancy or childhood. And those would be exceptions, or if there's a very early onset of cancer in the family. So sometimes we have a BRCA family where we see a breast cancer at age 20. So younger than the typical time when we would start screening. And in those instances, then it's a case-by-case discussion with the family or that individual to say, this is when we think it makes most sense for family members to consider genetic testing for that reason. As far as how the testing is facilitated, there are a number of different ways. Though I would say most often when we do genetic testing, we're either collecting a sample of your blood or some saliva. So many people are familiar with like some of those ancestry test kits and things like that. It's a similar collection process for the saliva. And the idea is we're basically using those materials to get your DNA that reflects the genes that you were born with, that you inherited from your parents, to do the testing that way. There are some circumstances where we need to use other types of tissue for genetic testing. So it can be case by case, but most often blood or saliva is how we facilitate that genetic testing. So it can be fairly simple as far as how to actually collect the sample to get that information for you.
All right.
And I think there's one other question about, does everyone need to be tested? And I think that that's a big debate. So currently, most often, at least here in the US and thinking about our healthcare system, there are criteria that we often use. So guidelines, one group is called the National Comprehensive Cancer Network that says, here are the criteria, or here are when we should consider or offer genetic testing to people for cancer susceptibility. And it could be to guide in things like treatment that Dr. Braun can talk more about if there are questions related to that, but also to understand for early detection or risk reducing or family planning purposes. And so that's often what we go to, and that also then reflects whether or not insurance will cover the cost of the testing. So that's the other sort of thing that comes into play sometimes for folks in thinking about whether or not they want to pursue testing is the cost. So those are some factors. There are some policies, guidelines, whether here in the US or abroad, that are advocating for what's called population-based screening. So testing everyone, given the potential benefits of identifying risk factors that you can be proactive about. And I think that it's just mostly debated because of thinking about how do we facilitate this in a responsible way to make sure that people are getting the appropriate level of care that they need. But there are, because of that, I would say there are increasing number of research studies and other things where genetic testing is also being offered as part of these studies to try to better understand how we might be able to facilitate that. So I think it varies depending on your health system, where you live, but most often the folks that we're offering or recommending, I should say, genetic testing to typically will have a personal or family history that puts them at an increased suspicion that they may have a predisposition to cancer.
Hey, thank you. So switching gears a little bit and speaking of being proactive, Dr. Braun, would you share the latest in screening recommendations for women, men, anyone with a family history of cancer?
Absolutely. So, as Peter was saying, there are many different syndromes, and the syndromes present in different ways. Kind of like how the same one gene might make your eyes, green or blue. Another gene might, might decide like, how much acne you get in puberty. So these genes have do all kinds of different things in your body. And so depending on what what we call the phenotype, which is how these genes actually cause, some sort of change to what, the normal lifespan of the average person, really depends. So for something like BRCA, I know we just talked about at length, but things like breast, ovarian, would be the most common, then followed by things like in men, prostate cancer, or things like pancreatic cancer. And I saw a question in the chat about that, with BRCA mutation. So, but something like Lynch syndrome, which, can cause other types of cancers, leads to other screenings. But in general, something kind of general rules that apply to all genetic cancer predispositions is almost always, if somebody had a cancer in a genetic condition, you want to start screening them like around 10 years before. And the reason for that is that cancers, even when somebody has a genetic predisposition, they take time to grow. And so you can catch them at any sort of phase along that. And obviously earlier is better to find them, because then either you can just monitor them depending on what it is, or you can get them out, before needing to undergo bigger procedures. So general things, there are risk models that can be used for breast cancer screening. There's a few that are out there. There's the IBIS, there's the Gale risk scores, and things that when you talk to either your genetic counselor or to your whoever your doctor is evaluating that, can help you decide when you start screening. So if you're like 25 and you know that your parents, your mom had breast cancer and your grandmother had breast cancer, that might be a reasonable time to start, even though it feels very early. You can start with things like MRIs, which don't give you any radiation, so they can be safe. And you can do things like ultrasounds. And then once you get into your 30s, people tend to start doing traditional mammograms, with sort of generally speaking, I'm speaking in broad strokes just because it depends on the condition. But there are other screenings that can be done. I think people know those kind of for the most part. But prostate, you can test for the prostate specific antigen, which is not actually that specific to the prostate cancer, which is a misnomer of the test, but it could be helpful. You can also do MRIs of that if there's some concern, and ultrasound biopsy. Pancreatic cancer, I saw a comment about this. You can do both MRI, you can do CT, and you can actually also do an endoscopic ultrasound, which basically you take a camera or you go to a gastroenterologist. You don't do it. The gastroenterologist will look down with a camera. It's like a 20-minute procedure, where they go in, they stick an ultrasound probe on the very end of it. It's very small. And you can look through the stomach and see what the pancreas looks like. And that can be done on like an annual or more basis, depending on what's needed. So there's a lot of different options, and I think that's why doing that first part of making sure you need screening, is much more important to help guide all the many different ways you could be screened. I think that's maybe the real takeaway.
All right. Thank you. Yes, I just before I even knew about the BRCA1 mutation, just based on family history, my general doctor had asked me to get a baseline mammogram at 28,
Yeah.
just so that get it way ahead of everything. So yes, that sounds pretty on par with what you said. So how can knowing what someone's family history about a genetic mutation impact their treatment if they are diagnosed with cancer?
This is one of the most confusing and parts of cancer treatment, is that you might be at higher risk for cancers, but it actually opens up treatment opportunities because we understand so much about how these genetics cause the cancer, that like 50 to 70 years of research has been dedicated to figuring out what we can do for people who are getting many cancers. So depending on the condition, like I saw there was a comment about Lynch syndrome, that generally speaking makes people more responsive to chemotherapy and opens up oftentimes immunotherapy. The problem is that these things are genetic mutations that affect how you recover from damage often to your DNA. And so when you depending on what kind of chemotherapy and stuff is offered, that actually might increase your risk for subsequent cancer. So it both can open up the possibility of a successful treatment for any particular cancer, but it might also open up the harms of that chemotherapy for causing future cancer. So usually when people have these sorts of conditions, and BRCA has something called the PARP inhibitor, which is a very famous, it's already been FDA approved, and there's been multiple FDA approved for both prevention of cancer and also for the treatment of both breast and ovarian cancer, and actually also for pancreatic and prostate cancer. They all have, because of the way that the PARP inhibitors work in BRCA, so that's a very specific indication, is it kind of hyper agitates the cancer. So BRCA might affect how it can respond, but the PARP inhibitor makes it so that the BRCA gets like overstimulated with responsibilities to the point where the cell can't even survive. And so that can be an interesting, it's an interesting treatment, and I'm sure there's a lot of, good patient information out there about it, but it would be something to, so depending on the genetics, it opens up different treatment possibilities.
All right. That's interesting. So what else can people do if they test positive for a BRCA or other mutation? What other options do people have?
Yes. So I know that this has been mentioned about the prophylactic mastectomy, and then so that means that years before you would ever develop a cancer, so this is not mastectomy for the treatment of any breast cancer. You would remove all of the breast tissue, and the breast tissue, obviously, people have an assumption it's sort of kind of what's around the bra, but it actually goes up into almost to your shoulders and into your armpits. And so when they do the mastectomy there, they're trying to get every area that there's any breast tissue, because that area is no less affected than where most of the breast tissue is. And then additionally, there's always a question when it comes to mastectomy about the nipple. I think that comes up a lot about whether or not to prophylactically remove the nipple or not. And that one is, I think, worth its own kind of discussion if anyone's considering that, because there's a lot of nuance about it, and there's a lot of, personal identity around your appearance and also just your sensation that make it a complicated decision that's very individualized. But this kind of in general will reduce the lifetime risk of breast cancer by over like 90%, depending on who you ask, even higher. So that's obviously a very good option, and pretty challenging to recover from, but not impossible to recover from. I think there's a lot of organizations like Charchet who can find you support if you're considering that. I think the other thing that people talk about is for the bilateral salpingo oophorectomy, which is jargon for removing the fallopian tubes and the ovaries. I know that we're going to talk about this a bit later, but that removal, again, sort of after kind of childbearing times, or potentially before if you're open to fertility conservation, which is basically fancy for egg retrieval, you can remove these and remove a huge amount of the risk of ovarian cancer, which in BRCA is probably one of the bigger fears of the condition. And so that's another very good option that is individualized about the timing, but the benefit has been clearly defined.
All right, thank you. Switching back to Beta, can you describe the different options that are available for testing? We have recreational testing versus just the BRCA founder mutations versus a full medical grade panel.
Yeah, definitely. So there are different types of genetic tests that we may offer or discuss with folks depending on the circumstance, and also depending on when you had your genetic testing. You may recall Lisa shared that she had genetic testing many years prior, but then had updated testing. So there's different reasons for having different kinds of tests. So when we think about sort of recreational, I'll start there, recreational tests, and examples of that are ones where you don't necessarily need to go through a healthcare provider, but you may sort of go online and purchase the test. And there are even different sort of flavors and varieties of that as well. So one example people often hear about or are familiar with is something like 23andMe, which is not a medical grade test. They do now include testing for some BRCA mutations or sometimes other genetic changes that can impact risk, but it's not medical grade. So any of those types of tests, whether we do or don't find something on those, always need to be reconfirmed with a medical grade test, because what we found is that there can be false positives and false negatives just based on how that testing is done versus medical grade testing and its interpretation as well. And the sort of one of the other examples I give is that they initially just tested for a few mutations. Now they include like 43 mutations, but we know that there are well over 500, I think even over 1,000 different mutations that have been observed in BRCA1 and 2 alone. So you're just not going to be getting comprehensive testing. And if you're already going to go through that process, you want to make sure that you have accurate results. So that's sort of some key differences between sort of recreational testing and medical testing is really just knowing what are the limitations of like what it can and can't tell you. With the medical grade testing, then when we do the genetic testing, again, this is where family history and maybe knowing if other folks in your family have already had genetic testing, if there's already a known, gene mutation in your family, that might change our approaches to thinking about the type of tests that we offer you. So sometimes when there's already an identified mutation in the family, folks will just opt for testing for that particular gene change to see if they have it or not. And then it's a yes or no answer. Whereas other people would say, let's look broadly if I'm going to go through the process, or there are maybe cancers in my family that haven't been accounted for or explained by that mutation. So some people will just get tested for the gene change once it's known in the family. The Ashkenazi Jewish founder mutation. So in the past, we used to just test for those 3 more common mutations if it was someone who's Ashkenazi Jewish getting testing. But again, like I said, those are 3 of many different mutations we can see. And so again, that's where you might need to go beyond that testing if you don't have an answer yet for your family or for other reasons. Then there can be single gene where you just look at one gene alone. But I would say what's most common practice these days for genetic testing for cancer susceptibility is what we call a multi-gene panel. And what that is again, it's that same blood or saliva test, but we are looking at a series of genes together. We're spell checking all of these particular genes of interest. And those panels can vary where some people say, I'm going to get tested for genes primarily linked with colorectal cancer or pancreatic cancer or breast cancer. But we know that we often will also order panels or offer panels that are more comprehensive that cover a broad spectrum of cancer types. And so some of the benefits of that approach is these days, it's become more cost effective, just given the types of technologies we use, where it would be the same cost to you to include those additional genes. The other thing that Dr. Braun shared earlier, right, is that each gene, sort of presents and has different cancers associated with them, but a lot of them have overlap. So for instance, when we think about breast cancer susceptibility, there's probably about 12 to 15 genes we routinely think about, or ovarian cancer susceptibility, 15 to 20 genes, so it varies from cancer to cancer. And because we don't know for certain, we have some ideas based on your family history, the panel is an opportunity to sort of cast a wider net and be more comprehensive in that way. The downside is that there's more information, right, that may be a surprise or an incidental finding that maybe you weren't expecting. Or like Elisa shared, you can have a variant of unknown or uncertain significance. So gene change where we don't know if it's linked yet to increased cancer risk. And that's part of that pre-test discussion that I have with patients so that they can be fully informed to understand and help decide what test is right for them. I'm going to link this in. There's a question about are genetic and genomic testing the same? And so sometimes those terms are definitely used, I would say, interchangeably. But the other piece that sometimes genomic testing or molecular or somatic testing is also used to describe what Dr. Braun probably deals more with in his practice, where when I do genetic testing, I'm often talking about, let's test the genes that you were born with, that you inherited from mom or dad, to look for changes that may have put you at a higher risk to develop cancer. But we know that there also can be genetic changes that are unique to the cancer itself. And so doing genetic testing of the cancer as an opportunity to understand more about that and opportunities for treatment. And so these days also sometimes there's paired testing where we test both at once, or other factors. And so genomic might, kind of applies to the genome. So thinking about all of our genetic material, but that term is sometimes used interchangeably to describe the genetic testing that I just explained, or other types of tests as well. So they're sort of the same, but sometimes there's a little bit of differences depending on the context that you're using that word.
Interesting. Thank you. So what are there any downsides to having genetic testing? Cost, insurance, any insurance ramifications to having testing?
Yeah. And Elisa also touched on this as well with her experience, and that I think, concern about insurability, which was more of an issue, I would say, in the past, less so, in this era. So, we talk a lot about, the pros as far as information and having that knowledge in advance when you do genetic testing. Some of the downsides, so one is, for some people can be cost. So I would say thankfully it's something that's increasingly being covered by insurance because of the recognized benefits, whether for treatment or prevention or early detection. And the cost of testing has gone down significantly. So what used to cost in the order of like $5,000 to $6,000 to just test BRCA1 and 2, these days, many of the commercial laboratories that offer testing will have cash pay options for 80 plus gene panels that are like $250 to $350 cash pay if insurance does not cover. So it's definitely become more affordable, but that's still a lot of money. And so that's a consideration, especially when you think about other costs of healthcare or just life costs. So that can certainly be a barrier or a downside for some people for undergoing genetic testing. I'd say the other piece, and this is why I talked about genetic testing as a personal decision, for some people, they may not be someone who can handle or tolerate, like that risk or that information on a personal level. And it can be emotionally distressing to think about that. And so we have to sort of weigh those pros and cons and think about, well, what are other strategies for you if you do not want to pursue genetic testing? So for some people, the information can be distressing to have that. But I would say the most common concern that we do get and questions is just related to what's called genetic discrimination. So how can my genetic information be used against me? And that used to be a much more prominent issue up until about 2008, 2009. And that's when we had what's called GINA, the Genetic Information Non-Discrimination Act, came into play and was signed in as federal legislation. So it's a federal law that protects against some forms of genetic discrimination. So not all, but it protects against specifically for health insurance and for employment. So your employer should not be able to use this information against you. Similarly, your health insurance. Where GINA does not have protections are in areas like for members of the military. So that's one thing to keep in mind. But then specifically for things like life insurance or disability insurance, because those are sort of commercial or financial products, they're just not protected in the same way. There may be additional protections depending on your state. So California has its own additional version of GINA. And so it can be confusing to navigate because it can vary from state to state. And there are a lot of nonprofits that help to understand that, and legal resources for those who want to know more about that. But I would say because of things like GINA, those protections, it's thankfully less of a concern about insurability and other things. We do sometimes talk to people about if they're thinking about pursuing testing and they're concerned about life insurance, to secure life insurance in advance of undergoing genetic testing. But GINA itself will protect against genetic testing information, but also things like your family history. The few instances where, at City of Hope, our genetics program has been in effect since like the mid 90s. So also well before GINA was in place. But sort of the few instances where we've run into things from just our patients and their experience, actually, it turns out was related to their own personal diagnosis of cancer, that was considered a pre-existing condition. And that's what impacted their life insurance, like their ability to get life insurance. So I think that that's something else that, thinking about WeSpark and, the people that are part of your community is sometimes it's your own personal history of the cancer itself that is, sort of the quote unquote issue with access or maybe insurability or other factors. But thankfully, the genetic testing piece and genetics itself has become less and less of an issue with the added protections that we have in place now.
All right, thank you. And then one more really quick question. We touched on retesting a little bit, but say 5 or more years ago, have the tests changed significantly, and what should people consider if they do want to get tested again?
Yeah, that's a really good question. So in general, when I meet with people, I will always say check back in about 3 to 5 years just to see, and that might not necessarily be when we would definitely do another test, but that just lets some critical time pass where there might be new genes or technologies available to test, or your family history or personal history may have changed to warrant additional genes that maybe you weren't tested for before. So when we think about like historically with the testing itself, be it something like Lynch syndrome and the BRCA1 and 2 genes, which were sort of the more key and prominent and still are hereditary cancer syndromes that we were testing most frequently for, I would say that like pre-2010, that testing was much more limited as far as maybe sort of the entirety of the gene that was looked at or the technologies used. And then in 2012, 2013 is when there was a Supreme Court decision about the BRCA1 and 2 genes and a patent on those genes saying you can't patent genes. And so it used to be that there was one lab that had monopoly over genetic testing. And that time frame is when we just saw an explosion of labs and also these multi-gene panels to be able to offer broader testing to people and increase access. So I think definitely like because of that pre-2015, many people may have not had a panel, but may have had their testing limited to just maybe a couple of genes or even a couple of mutations within a gene. It's helpful to reconsider testing. But then beyond that, I would say a good benchmark is every 5 years or so, or if there is something that changes within your own personal or family history, meaning a new diagnosis or a family member who's undergone genetic testing, to then recontact your healthcare provider that is part of your genetics care and say, hey, these new things are happening or nothing has changed, but are there new tests available that would be worth the retesting or the updated testing?
Okay. And so we hear all the time from families, how can things be different for our children? So Dr. Braun, can you share any new screening technologies that are in the pipeline to help us with the next generation?
So with the genomics conversation from before about how genes were detected within cancers that helped us kind of understand how the cancer might develop, people are trying to do the reverse, which is that we now have found many genetic changes within cancers that we can actually detect in the blood, right? And so the question would be, well, this is a very open question. This is definitely not a closed question, but there is the question is now, if you can detect some sort of circulating blood genetic changes early on, could you find, pre-cancers, early stage cancers and stuff that wouldn't have shown up, on some sort of traditional screening exam, or we don't have good screening? That has been like a multi-year long effort run out of many different countries that I think is unfortunately not so clearly the catch-all, like kind of the holy grail of catch every cancer before it develops. But I do think there is this growing benefit, and I think especially in like patients who are kind of like the people in this conversation who have a high risk of developing cancers. You combine that with something like whole body MRIs or things like that. These are other ways that people are looking for high risk families who have a lot of cancer in them that you get the panel isn't clearly you have BRCA, or you have Lynch syndrome, you have something like this. For those kinds of patients, there are these new developments that might pan out to be like a new age screening combo, although it's definitely in the research phase.
All right. And then just thinking about ovarian cancer, I know I've heard and from many genetic counselors and doctors that there's really not great screening for ovarian cancer. So is there anything on that end coming up in the pipeline as far as new screenings, research?
I think that, this is this is a generational goal. I think it is the ultimate plan, but it is not. I'm not aware. I mean, maybe I'm out of date on some of this, but I think in general, the classic kind of cancer, tests like CA-125, which people bring up a lot, ultrasounds and things like that, they do miss too many. And so that has been one of the hardest parts, I think, about preventing. And that's, I think, where the prophylactic salpingo-oophorectomy has been so important for BRCA.
If I could, maybe I'll add on Dr. Braun related to specifically with ovarian cancer. So I think there are a couple of things that we think about, and there are pros and cons to this, but sometimes we'll talk about oral contraceptives for some women because that has been shown to reduce ovarian cancer risk, but certainly not to the level of then, saying you don't need risk reducing surgery if you have a high risk for ovarian cancer. So it's not perfect. I would say what is sort of the hotter topic right now for some of these hereditary cancer syndromes, particularly for BRCA1 and 2, where the ovarian cancer risk can be anywhere from 20 to 50% in a woman's lifetime compared to like less than 2% for the average woman. So it's significantly elevated. We're looking now at actually removal of the fallopian tubes as an alternative to having to remove the tubes and the ovaries. And the thought process behind that is that, we think that most ovarian cancers actually arise in the fallopian tubes themselves. So the idea is if you can be opportunistic and remove the tubes, and even some people are looking at if you're going through tubal ligation, maybe you should just have your tubes removed entirely because of that. But it's not perfect because we don't know about the appropriate timing. There are obviously a number of different factors, for women who are of childbearing age, then they would have to use IVF, right? If they wanted to, pursue pregnancy after that or other factors. But there are a number of research studies that are following maybe women who aren't ready yet to take out their ovaries, to just remove the tubes to see how that might impact overall ovarian cancer risk. But at this point in time, the recommendation is removal of the tubes and ovaries when you're done with childbearing, or, generally between 35 and 45, depending on the particular cancer syndrome. But I'd say that's where people are most excited. But I think the jury is still out and we still have a lot more research to do to know if that's going to be a safe and effective strategy for reducing ovarian cancer risk.
Thank you. And then Dr. Braun or Vita, either one of you, is there work being done on BRCA mutation or other mutation prevention?
Like prevention of getting the gene, for example.
Yeah.
So I think, this is always another sort of personalized decision, but for people who have, hereditary cancer, in their family, they can be screened for with genetic testing. So if we can prove that there's the genetic, genetic finding there can be sort of prenatal, or pre-PGD. Before you even think about having kids, you can actually, first of all, screen if you have it. If you do have it, you obviously will get plugged into screening, but also when you can talk to, reproductive and fertility specialists who actually can screen eggs and specifically and embryos so as the embryo grows, you can actually take a small sample and see if that embryo has the gene, and then theoretically you would be ruling it out. So because that embryo should all be all the same, just like a person in that way. And so when you follow it out, that eventual person should not have the BRCA gene. Since it's autosomal dominant, it's only a 50% chance they have it.
Thank you. Actually, and you just reminded me, tonight we're actually hosting a webinar on PGT alone. So we will if anybody wants more information about PGT, pre-implantation genetic testing, you can join us tonight for a free webinar. And then Beta, when people do leave here today and they're eager to speak to a genetic counselor, where do you recommend would be a good place to start?
Yeah, it's a really good question because it can sometimes be hard to identify genetic counselors or genetics providers. And so there are a couple of different options. Share is obviously a really good resource. There are genetic counselors on staff that you can, reach out to through the website, to get more information. And so that's certainly, I think, a really good resource for folks who are interested. The other sort of broader also resource that we think about, and I can find that link and put it in the chat, is through the National Society of Genetic Counselors, or NSGC. They are the sort of in North America, they are our professional organization, and on their website, they have a link to a button that says Find a Genetic Counselor, and you can search by your zip code, by specialty, whether you want to see someone by telehealth or in person, and that can provide you also with a list of genetic counselors to seek out. I'd say beyond that, there are obviously like some of the larger hospitals and centers, like if in the Los Angeles area, often will have a genetics team like we have at City of Hope, but also at other hospitals. And so sometimes it's also just a matter of depending on the health system that you're in, to speaking with your provider to say, I would like to speak to someone, for genetic counseling and testing. And ideally, I'm a genetic counselor, so I'm master's trained specifically in genetics, but there are also genetics nurses, there are genetics physicians, and then there are folks like Dr. Braun and others who are also skilled and understand nuance to genetic counseling and testing. So I think the key is just making sure that you are meeting with someone who is comfortable and knowledgeable in this area so that they know how to facilitate the right testing, but then also to be able to interpret and act on your test results depending on what your results are. But those are just some of the approaches and how you can find a genetics provider.
Thank you. And then what happens in the case where we have families who test negative for all mutations, but still have a strong family history of certain cancers?
Yeah, it's a really good question. So when we do genetic testing, you can have a positive test result, meaning we found a mutation, and that mutation may or may not explain all of the cancers in your personal or family history. So that's something also to keep in mind. You can have a negative test result, like Melanie was just asking about, where we don't identify any changes. And then sometimes you can have a variant of uncertain significance, like Elisa first described. And how we approach those is different depending on a number of factors, mostly like your personal and family history. So if you had genetic testing and you had a broad panel and it was completely negative, we don't know if you are negative because maybe there's a mutation in the family that you just didn't inherit. Because remember, there is just a 50-50 chance. So maybe that's what's going on. Maybe it's just a gene we haven't discovered or our technologies aren't able to pick it up. And so when we don't have that explanation, we fall back to your personal and family history to run calculations or use guidelines then to say, here's what you should be doing for screening. So Dr. Braun talked about like the Gale model or IBIS, or it's also known as the Tyrer-Cuzick tool. So these are models that will take into account things like your reproductive history, like when you started your periods, or if you've had breast biopsies, your genetic status, et cetera, that will help to calculate and understand what your remaining lifetime risk is for breast cancer. For other types of cancers, we usually will use large-scale studies to say, well, based on these family histories, here's the estimated cancer risk. So then we say, well, I have a family member, like a dad, with pancreatic cancer, and then we can say, well, this is what your estimated risk is for pancreatic cancer just based on your family history alone. And then depending on the risk number and the type of cancer, there may be corresponding screenings that are recommended for that. So with breast cancer risk, we think about, are you a woman who would benefit just from mammograms, like sort of standard screening, or should we be adding things like breast MRI or ultrasound to your screening regimen? And should we be doing it at a younger age than the average person? Or with colon cancer, if you have a family history of a first-degree relative, so a parent or a sibling or a child with colon cancer, we generally will start at age 40 instead of 45, unless, like Dr. Braun was saying, where there was a younger diagnosis in the family, in which case then we would go even 10 years prior to that. So, so we fall back really to your family history and then other sort of intrinsic factors that you may have to estimate what your risk is, and use that to guide what the current screening recommendations are for you.
Thank you.
Mhm.
Dr. Braun, there's so much confusion out there about when to start and how often to get a mammogram. In general speaking, without knowing a specific mutation or family history, what are your general recommendations?
So there are three different, screening guidelines. There actually might be more, but there are three commonly, reflected ones, which is like the American Cancer Society. You have the American College of Obstetrics and Gynecology, and then did I say, and the American College of Radiology. And so each one has a slightly different idea. And the reason why any screening test is developed is because the hope is that you're catching a lot, and that when you catch it, you catch it reliably. And so if you can catch a lot, but you're not catching them reliably, or not, then it's not a particularly good screening test, because you get a lot of, you don't want people to do a lot of testing and then get falsely reassured. So that generally speaking, those kinds of tests don't make it. And then you want it to be reliable, just for many reasons, so that you know how often to do it, and et cetera, et cetera. So things like a mammogram will catch, 2/3 to 4/5 of cancer, something like in that range, even under the best circumstances, done properly. And so, but breast cancer grows slowly in general. And so the screening is usually every 1 to 2 years, depending on which guideline you use. I tend to go with once at 40. And then depending on what you find, you either wait a few years or continue annual testing with a mammogram, just because it's not a ton of radiation, and you know that you're missing some. I would say the most important thing for patients to know is that if you have a lump or something that you feel and you get a mammogram and the mammogram is negative, okay, and that the mammogram does not see what you are feeling, and you're like, I know my chest, this is weird, and the mammogram is negative, then that does not mean you are done. Because again, the mammogram it's not quite good enough. So that is when you actually go ahead and do a biopsy. The teaching would be to do a biopsy no matter what, if you can't prove that it's normal. So I know that's sort of like a lot of ifs, thens, but basically you want to have closure whenever you have found something. And so that's sort of the flip side. So for somebody who you don't know if they have any cancers, you do this annual screening. If you feel a lump, but you don't know, then you go until you have closure on what that lump is, if that makes sense. Um, and I think we talked a bit about hereditary screenings, but generally speaking, about 10 years beforehand, if you know there's a family history of cancer or there's a high risk, and that generally speaking, that started at 25, at the earliest. And that's MRIs until 30, mammograms thereafter, and combined with an MRI depending on the case. Again, even if you're 22 and you have a weird lump, that can still be ultrasounded. Some people do get breast cancers in their 20s, and not to scare anybody, but the point again is that if you notice something, if you see something, say something, is kind of if you feel something, say something, So that's it never hurts to get someone to look at it.
Yes. And what is the relationship between age and cancer risk? And specifically talking about how a young person with a hereditary gene mutation could be proactive with screening before the generally recommended ages.
Yeah, and I think we talked about this in a few ways, but if there is hereditary cancer risk, you definitely want to make sure you get to either the genetic counselor or a well-versed, clinician of some kind to talk about it. I would say age is a strange variable, because age really is the acknowledgement that throughout life you have exposures to things. Your genes, as your cells are healing, they can make errors, and over time your risk of just something happening to you goes up. Age is not a particularly important factor once you have the cancer, right? Because yes, sometimes it might change your treatment, but ultimately it doesn't mean anything. The cancer is there, right? So, oh my gosh, I can't believe this cancer. Well, that's true, but we also have the cancer. So now we're going on a different journey. Generally speaking, cancer for the general population, breast cancers tend to develop more after age 45, 50, and same with colon cancers. Pancreatic cancers usually present actually a bit later, and then that, but there's every cancer has its sort of age distribution, which I wouldn't think too hard about because I don't know how an individual uses that information to particularly reassure themselves or freak themselves out. So that's more for us to nerd out about and for a patient to kind of forget about, in my opinion.
Yeah, thank you.
Mm.
Okay, so we did get a couple of pre-registration questions from attendees. So I'm going to go through a couple of those and then we can open it up to the broader Q&A. But the first one I have here is, how can I be cautious as a provider, specifically Lynch positive person?
Yeah, I'm happy to start off and then Dr. Braun, if you have anything else to add. And I'm not sure if, just in case folks are not familiar with the term previvor, but that is also just describing someone who's been found to have hereditary cancer risk because of a gene mutation, but has not yet developed cancer. And ideally, that's where we want to find as many people as possible so that we have opportunities for prevention or early detection. And so, specifically for someone who has Lynch syndrome, which can be caused by a handful of different genes. So there's a number of different genes. I think the things really to think about, so those folks are going to be at a higher risk primarily for things like colon cancer and uterine cancer, but there are many other cancers on the list for Lynch syndrome. And the level of risk and the types of cancers also depend on the Lynch syndrome gene that you carry. So I think, key thing, particularly given the prevalence of colon cancer, is making sure you stay on top of those particular screenings. What's amazing about colonoscopy, as much as they can be a literal pain in the butt to do, but what's amazing about them is actually they are a screening tool that can actually prevent cancer, because if you find a polyp, you remove the polyp. So whereas other screening tools, the goal is early detection, there's an opportunity there to prevent a colon cancer from happening with colonoscopy. So I think staying on top of your screenings and staying connected with someone who is going to also stay on top of the guidelines related to Lynch syndrome or other hereditary cancer syndromes is really important, because actually the Lynch syndrome screening recommendations continue to change over the years as we learn more about gene-specific risks. So I'd say that's number one. And I think the benefit of also being well connected to a center or a provider who is well-versed in something like Lynch syndrome is they are also going to be familiar with the additional resources or other things that are coming out. So for instance, we've identified, that we know things like taking aspirin can actually help reduce colon cancer for people, risk for people with Lynch syndrome. So then there'd be an opportunity to have a conversation with your provider to find out if you are a good candidate to be taking aspirin, right? You always want to have that conversation with your provider to make sure that it's something that's safe and makes sense for you to do. But I would say with the other exciting piece specifically with Lynch syndrome that I think a lot of us are very hopeful about is there are actually currently vaccine study trials. So vaccines that are looking at reducing cancer risk for people with Lynch syndrome. So I think being connected with centers that are, involved in research or other things also may increase your exposure or opportunities to be part of those types of things if that's something that you're interested in, or at least to remain informed. And then I think, right, like organizations like Share We Spark, but there are a number of other organizations that support specifically folks with Lynch syndrome, or there are ones that exist for other hereditary cancer syndromes that have often like webinars or other resources or we'll send out notifications when there are new studies or other things out there, or other ways to continue to stay informed about these types of opportunities, or like the changing landscape as we learn more and our understanding evolves. So I'd say stay on top of your screenings as much as you are able to, and then also stay connected with people, whether providers or other support groups, so that you can remain informed as we learn more about Lynch syndrome or cancer or other genetic factors over time.
Dr. Braun, do you have anything to add to that?
That's excellent. I mean, City of Hope is a particularly well-known Lynch syndrome institute, so I defer to them.
Yes.
You were there for a bit, so it's always nice to
Well,
see a
3
familiar
years.
face.
Okay, so here's one more that came in ahead of time. What is the chance of recurrence with a BRCA1 mutation after a double mastectomy? And are there environmental or lifestyle changes I can make to reduce my risk further?
So the reduction is going to be over 90%. I mean, I think the exact number is going to be debated, but I think the point is it's definitely about that much. It might be even more. And I think the most important thing about the mastectomy is that it also, because of the way that it reduces so much breast tissue, it also changes the kind of screening you need to do. And so, because when you have you can imagine when you've done a mastectomy, it's hard to do something like a mammogram, because a mammogram, for people who haven't gotten one, it really requires there to be a breast tip to put into the right plane so you can actually do the mammogram. And so you can't do that if, after a mastectomy in the same way. So it does change what kind of screenings you can do, but it also limits you, or sorry, guides you to the right areas, along the scar, sort of up into the armpit, places where that there might be a higher risk after a mastectomy. I would say more importantly or not more importantly, but on the question of environmental and lifestyle risks, I think unfortunately it's sort of the same as you might expect. Not, unfortunately. Fortunately, it's something that you're probably already doing, which is thinking about what you eat. So making sure that you're doing reliable exercise. More exercise means more cancer prevention across the board for all cancers. I don't think there's a single cancer where it's been shown not to have a beneficial effect, if that makes sense. Additionally, things like alcohol have been shown to increase risk of breast and ovarian and colon and a few other cancers. So that is something to limit. I think that's again a personal decision for everybody about what is like a reliable amount. The current recommendations now are 0, which is, I think, for a lot of Western people, impossible. Western people, anybody, is pretty hard, especially if you're, I'm sure there's a fair amount of Jews here who do it ritually. So some say the risk really starts to go up after about 3 alcoholic standard drinks a week. And so if you want, like, kind of, you're like, I can't live a life where I'd never have a glass of wine. Well, okay, 3 glasses of wine a week is like where I would put the after that, the risk starts to go up of developing cancers. So yeah, I think that's a good place to stop.
Yes, thank you. Okay, so Michelle, do you want to help go through and ask some of these questions that came in through the chat?
Yes, absolutely. And I actually have a couple of more here that came in last minute yesterday. And then I promise I'll get to the chat. One of them is I have Lynch syndrome, and if this has already been covered, please forgive me. I have Lynch syndrome and have the MAX gene for predisposition to renal cancer and pituitary adenomas. Both parents passed away from terminal pancreatic cancer. Mom also had cancer of the bile ducts. I had endometrial clear cell cancer, and my sister passed away from MMMT cancer. The entire family was exposed to DDT, malathion from trucks in the 40s, 50s, and 60s. What should I watch for?
I think this is a tough situation for many reasons, because a lot of these cancers are rare in and of themselves. It's rare subtypes of common cancers or rare cancers in general. But I think something to think about and I'm sure Vita would, well, I'm not going to speak for Vita, but they're, again, kind of going back, instead of saying, what kind of like genetic things, standard screenings can I do? I don't think there's going to be necessarily standard screenings for some of those more rare cancers, but I would say clinical trials are available for screenings, where like places like City of Hope and other places will have from time to time these screening programs for patients with high risk of cancers that aren't well studied. And I think that would be a place to look for that particular rare situation.
Yeah, I would agree. And I think if I heard you correctly, Michelle, this person had shared that they have not only Lynch syndrome, but also the MAX gene. Was it MAX?
Yeah, it was, so sorry, MMMT.
I think that might have been the cancer
Yeah,
that
I
their
think, I
family
think it
member
was the
had.
Mac. I think it was the Mac. That's what I
Max
heard
gene.
too.
Okay, yeah.
Okay.
Yeah, and so so that gene is also a less common gene, but is one that has certainly been associated with an increased risk for what are certain types of neuroendocrine tumors, like what's called pheochromocytoma or paraganglioma, so less common cancers. But I would agree with Dr. Braun. Obviously beyond following the guidelines, specifically for those as far as like dictating certain types of screenings, and then I think clinical trials can be a really great opportunity to also explore maybe like other early detection strategies and or opportunities to participate to learn more from that. In general, I think then it's just having a conversation also with your healthcare provider about like those exposures or any exposure history that you're concerned about, to see if there is anything differently related to that, because it's such a case by case basis. The other group, just from a support standpoint that, might be of interest to you, just related to the MAX gene, is what's called the PHEO-PARA Alliance. So they are a support organization for people who are at elevated risk for the pheochromocytomas and paragangliomas. And I'll see if I can find that link to share it in the chat. But they also are probably going to be very much up to date and informed as far as resources and other things that might be of interest to you, just to stay on top of. But I think maybe just having a conversation about your specific exposure history, but even then it's very challenging really to know, sometimes. And so it's just a matter of, keeping on top of lifestyle factors, the screenings that, you should be doing, and then depending on exposures, whether or not there might be something else they would recommend for you is what you could consider, I guess.
Thank you, guys. And the next one that came in yesterday, a very healthy 20-year thyroid cancer survivor who is BRCA2 positive, has a high PSA in the 8 to 10 range, a cyst on their pancreas. Both have been monitored with 2 biopsies, 10 MRIs, and 1 endoscopy over the past 15 years with no tumor detection or growth. Even though I'm BRCA2 positive, do I still need yearly surveillance of these areas after 15 years? What is the current recommendation?
So when it comes to any kind of cancer screenings, there's 2 things I would always think about. Again, is how reliable is this test going to be to catch something? And then the other part, which we kind of talked about before, I would say the other part that's important is sort of your own kind of personal desire to undergo ongoing screening. I think, especially when you get into your 70s and 80s and you haven't had that specific cancer that you've been screening for, back to the age question is like, what is the likelihood it's about to develop? I think it's hard to argue that that you're going to catch it in sort of like the right time where you can actually undergo significant therapies to get rid of it and stuff like that. But I would flip it the other way too, which is that if you're 72 and you're feeling great and you have a long life ahead of you, no other medical problems, I don't see why you would necessarily stop screening for it, because pancreatic cancers do arise in the 60s and 70s, even when you have a genetic risk. And so you're kind of at the high time to find it. You've maybe been screening for it and you feel like, man, it's not coming now. It's not coming ever. But that's the problem with screening, is that it's not just because we did the screening that we're going to find cancers. We're doing the screening so that if we find a cancer, we're happy that we found it when we did. And so that's how I would look at it, is this something that I want to keep screening for? Because then if I find it, I'll take care of it right then and there. And That's sort of how I approach my screenings for patients.
Yeah, and I would agree with Dr. Braun on that. So we think about if this is someone who we would pursue treatment for the cancer if it was detected, then that could sometimes be sort of a test or consideration, litmus test to decide, if they should continue with screening. But it is very much individualized. So having that conversation with your healthcare provider to take into account if you do have other like sort of health factors to decide what makes sense. Current guidelines, at least for like when we think about BRCA 1 and 2 for screening in general, there isn't an upper age limit. So that's why it can be confusing and controversial, but at the same time, why we make it a case by case basis because everyone is different. So there isn't an upper, like to sort of like what is the current recommendation? There isn't an upper age limit. So it's really then the recommendation would be to speak with your medical provider to make that individualized decision. And I would say with pancreatic cancer specifically, like they are expanding and becoming more inclusive as far as when we will recommend screening for pancreatic cancer for some of these hereditary cancer syndromes like BRCA2. So at this point, we say that it should be offered to anyone who's 50 and older, where we do those endoscopic ultrasounds and the specialized MRI. And there are a lot of research studies out there actually now that are also trying to better understand the benefits of screening and sort of timing and things like that as well. So for people who are at risk for some of these less common cancers, encourage you also to consider joining some of these research studies. So we have the benefit of learning from you too, so that we can improve, our guidelines and recommendations to make them more and more personalized to people too.
Wonderful. Okay, so we have seven questions in the chat, so I'll try and go through them as quickly as possible. Let's see. If we've passed our BRCA down to our children, when and what type of active surveillance should they start?
Yeah, I can start there, but again, I think it's there's the sort of guidelines for when we typically will start screening, and then plus minus maybe additional family history factors that might warrant earlier. So generally, if it, a child is known to have inherited the BRCA mutation, breast cancer is typically the screening that starts at the younger age for the types of cancers you'd be at a risk for. And in general, that starts around age 25, like Dr. Braun had described earlier. Sometimes that gets shifted a little bit younger, again, if there's family history to warrant screening at a younger age, but typically in the 20s is one sort of age range that I tell folks to consider, and or when maybe family planning is being considered, right? Some people might be looking to start their families before they would even start screening. And that's where maybe you're not doing active surveillance or screening, but having that information could be helpful for family planning purposes and things like that. So in the 20s for women who are at the elevated risk for breast cancer, whereas for men, some of the other screenings, be it prostate cancer or checks for breast cancer or pancreatic cancer for both men and women, don't happen until later. So for men, it might start more so like in the 30s or early 40s, depending on the circumstance, but as young as in the 20s.
Fantastic. Okay. Are gene and genomic testing the same?
Yeah, I think we touched on this a little bit earlier as well, but I think that they can be used interchangeably, but sometimes they'll describe sort of slightly different things. Again, gene is sort of one of the single pieces of genetic information that codes proteins and other things that are important for our bodies, and the genome applies to all of the 20,000 plus genes that make up our body, but sometimes people will use those terms interchangeably to describe the same thing.
Okay. Is there any correlation in the MSH6 and breast cancer? Any studies if there's a link?
Yeah, I'm happy to talk about this, but Dr. Braun, I don't know if you want to touch on any of it.
No,
Otherwise,
I mean, you can go ahead. I mean, I think, yeah, go ahead.
yeah, I think it's a really good question, and I think that it's been debated for quite some time about whether or not breast cancer is linked with MSH6 or Lynch syndrome in general. And that I think is coming from larger based studies or consortia that looked at women with breast cancer and then looked at the gene mutations that were identified in those women with breast cancer. And MSH6 specifically, there's been a little bit of like a signal, so to speak, that there might look like it could have some breast cancer susceptibility, though the risks right now are not well defined and also not at the point where we would change screening for all women with MSH6. So right now we really focus on family history and other factors to guide, what the appropriate screening is for those individuals. And we know, right, breast cancer is also just common. So it can be that you can have what we call sporadic cancer, so cancer that just happens by chance, in someone who has an inherited predisposition. So I think there's still, jury's still out in sort of fully understanding and defining it. But I would say MSH6 is like on the candidate list, but I think we're still figuring that out.
Fantastic. Okay. Let's see, is there a gene that has been newly found to be related to pancreas cancer? I read the CFTR1 could have an association with it.
Yeah, so I think Via, you might be talking about the CFTR gene specifically and not CFTR1, so I can talk a little bit about that. So we know that there are a number of genes that can play a role in pancreatic cancer risk, and a lot of it is also thinking about the type of pancreatic cancer and the mechanism. So when we think about BRCA1 and 2, Lynch syndrome, and a couple of other cancer predisposition genes, those are genes that can be linked to an increased risk of specifically what's called pancreatic ductal adenocarcinoma. So that's one type of pancreatic cancer. And then there are also other types of pancreatic cancer that are neuroendocrine related, that are related to other cancer susceptibility conditions. And then there's sort of a third category of genes that can cause pancreatitis, so inflammation in your pancreas, which in turn can increase your risk for pancreatic cancer. CFTR is a very well-known gene because it's a gene associated with a condition that's called cystic fibrosis, which many people are, familiar with on some level. It's a recessive condition, meaning you have to have both of those copies of your CFTR gene carrying mutations. So your parents were both carriers. You inherited mutations from both your parents for you to have that condition. And it's on most newborn screening panels as well. So these days, most folks are being evaluated for it at birth because there are interventions that we would want to take early in life because it can affect multiple systems throughout the body. What we've learned over time is that, that gene and that sort of pathway can impact the bile duct and other things. And so there can be an increased risk for pancreatitis. And in turn, that can increase your risk for pancreatic cancer for people with cystic fibrosis. So it's in that circumstance, whereas typically being a carrier, which is quite common, about 1 in 27 people will carry a CFTR mutation. That's one actually where the American College of Obstetrics and Gynecology says all women in pregnancy should be tested to see if they're carriers because it's just so common. But being a carrier is not like really sufficient to change your care at this time. So it is one that's been linked to pancreatic cancer, but it's not a prominent pancreatic cancer gene. And it's just more so because of that like pancreatitis related risk. Whereas there are other genes that we more routinely will test for when we're thinking about pancreatic cancer susceptibility, like Lynch syndrome, like BRCA1 and 2, other genes like ATM, PALB2, CDK and 2A. So again, that's where we do those panels. So we can look at all of those genes. And if there is an indication of pancreatitis in the family, then we will include pancreatitis cancer or pancreatitis genes as well. And CFTR is typically part of that. So I'd say it's not a prominent or often attributable like explanation for pancreatic cancer, but in some instances, we may evaluate that gene for certain families.
Thank you so much. And Bita, it looks like the other questions you already answered. So it looks like that's it, unless anybody else has something to add or any other questions. what an informative, amazing panel this has been.
Yes, thank you so much, Michelle and WeSpark, for inviting us to share this information with you. Beta and Dr. Braun, amazing information. I'm just going to put my email address in the chat right now, just in case anybody wants to get information from us or be connected to a social worker or genetic counselor. You don't have to go through the website form. You can email me directly, and I can make that connection for you. But Michelle is also going to send out a follow-up email, like I said, with some more information about Charsheret and the services that we provide and support and resources. And thank you so much, everybody, for being here today. And thank you, Elisa, for sharing your story.
Thank you all individually. Honestly, it was fantastic. So informative. Melanie, thank you so much for putting this together.
Of course, my pleasure.
All right, everyone, take care. If you have any questions, just give us a call here at the office and I'll be sending out the follow-up email.
Thank
Okay.
you.
Excellent.
Bye.
Bye.